それでは時間になりましたので、円卓会議。
It is now time to resume the roundtable discussion. So once again, I'd like to ask the co-chairs, Dr. Beverstock, Dr. Shimazono, please. はい。少し総括をということでお約束していますので、約束を果たしたいと思います。まずはじめに、ここに最低2人のジャーナリストがいらっしゃるということ。
Of the discussion we've just had. That's the first thing. The second thing is, this is a personal view. I don't know how many of you agree with it, but I think the way ahead is for the citizen organizations to try and use the legal system in Japan to challenge the position that the Fukushima Medical Authority, and if it's also true, the government is taking. I don't see any other route except, of course, as Gaston said, about lobbying through NGOs and other organizations like that. So I think it's important that the public learn what the situation is, and if it can't be done through a scientific convention or debate, it has to be done another way. So I think the next topic that will be good to discuss will be the thyroid cancer issue, and I want to introduce you to a paper. Yeah, it's there. I just have to get the right slide. Okay. I'll tell you a little bit about this paper. It isn't specifically about Fukushima. It's actually a paper summing up Professor Williams's view of how thyroid cancer develops. And he has a particular view. He's had long experience of observing thyroid cancer over decades, and he was a very prominent scientist in the context of the Chernobyl accident, and he is aware of the information that has so far been obtained by the thyroid survey. So maybe I should read what he says, because we don't have it in Japanese. In a section headed Evidence from Fukushima, the importance of imaging techniques in determining the recorded incidence of thyroid cancer and the problems posed by the increasing frequency of detection of small thyroid carcinomas are brought into sharp focus by the results of screening the population of exposed to fallout from the 2011 Fukushima nuclear power plant accident. Because of the increased incidence of thyroid cancer in those exposed as children to the Chernobyl fallout, a Fukushima Prefecture thyroid ultrasound program was set up to screen everyone under the age of 19 at the time of the accident. After 3 years, a lot more thyroid cancers than expected were found. Among the 300,000 individuals, 110 cases of suspected cancer were identified by fine needle aspiration, and 86 of the 87 suspected cases so far operated have been confirmed to be thyroid cancer. 62 of the cases were proven cancer occurred in about 51,000 adolescents aged 15 to 19, a prevalence of about 120 per 100,000. The expected Japanese incidence at this age is 0.8 per 100,000. So this is a very large increase. The scale of the apparent increase has led to considerable concern in the exposed population. Nodules of less than 5 millimeter were not subject to further investigation. So the true thyroid cancer prevalence can be assumed to be much greater. However, the evidence from age at exposure and latency, that latency is the gap between exposure and when the diagnosis occurs, suggests that the large number of thyroid cancers so far detected is not due to radiation from the accident. After Chernobyl, the risk was greatest in those who were infants at the time of the accident, falling rapidly with increasing age. None of the Fukushima cases so far were infants at the time of the accident. The youngest was age 6, and the majority were adolescents. It goes on to produce this graph, and the light blue, we've got age at exposure along the bottom, and we've got thyroid cancer frequency in the vertical axis. And the blue bars, the light blue bars, show the situation in Chernobyl. And you can see the very high value for those 1 year at exposure, 1 year old at exposure. And you can see in the purple bars, the first case, the youngest case of 6 years of age at Fukushima. And you can see that the distribution among the higher ages is quite different. So that's the second half, 10 years and above, is quite different from the Chernobyl. Now, this, in my view, does not mean that necessarily this is not radiation-induced. It means that it is not following the pattern that seemed to be laid down by the Chernobyl accident. So in respect of that diagram, he says thyroid cancer frequency, percentage distribution, by age at exposure to fallout from Chernobyl and in the first 3 years after Fukushima. The Chernobyl distribution shows the high risk related to young age at exposure to radiation with a steep fall with increasing age. The Fukushima distribution lacks any increased risk in the very youngest, and the increasing incidence with age is similar to the normal increase, suggesting that there has been no radiation-related increase in the first 3 years after the accident. The slight rise in those aged over 10 after the Chernobyl probably also represents the normal incidence. So now that's another subject. So he doesn't think that this is overdiagnosis, and I think it quite clearly isn't, because the advanced stage in which the some of the cancers were detected and operated does not suggest that. But there is the possibility in the future of overdiagnosis, overtreatment, and unnecessary operations. So that's the position as he sees it, and I know that that is very different from the way Professor Suda sees it. So I wonder if we could open the debate with you to comment on what you think of Professor Williams's evidence. This is all, more or less, all he says in this paper. Wait a minute.
Who wrote this comment? Williams. いいですか？反論して。
May I object? Well, first 3 years after Chernobyl, we had 75%, which was over 75% of the population were over 10 years old. When we look at the first 3 years after the Chernobyl accident. So that was the same situation in Fukushima and Chernobyl. So majority were over 10 years old. So in that case, the thyroid cancer incident increased in age over 10 years old. And then after that, we start to see the increase in the incidence of thyroid cancer among younger people, younger children.
First of all, I think what you have to bear in mind is that the very early cases after Chernobyl were not detected with screening at all. They were palpation by hand, and it wasn't until around 1996 that screening came in. So those first 6 years that he's talking about, there is no screening. So it is a different situation to that in Fukushima. Yeah.
Screening は行われ
Even without screening, in Chernobyl, the following year after the event, there's a numerous incidents of thyroid cancers, as I showed earlier. Can you take my microphone closer to your mouth, please?
Can you say that again?
スクリーニング
So in Chernobyl, up until 1990, there was no screening done up until 1990 in Chernobyl. まあ96年 So without the screening in Chernobyl, the following year after the incident in Chernobyl, there's a significant increase of the thyroid cancer in that area. So as I showed you in my presentation,
You didn't show the information in, let me get this back. You didn't show the information in relation to the age at diagnosis. You showed the increase per year following the accident. And yes, it looks rather similar. I agree it looks rather similar, but actually the age distribution of the people in Fukushima is quite different from that after Chernobyl.
そのデータは今ここに持って
I have the data, so I can show that to you if you would like to see that.
The data, you're presenting the data in that particular way, and Williams is presenting data in a different way, and he's presenting it in terms of sensitivity by age at exposure, and all he is saying is that if this is due to radiation here in Fukushima, it is not following the pattern that was observed after Chernobyl. Now, I'm not saying, and he's not saying, that these are not necessarily radiation-induced cases, just that they don't follow the pattern after Chernobyl. And the question is, why would that be different here?
ウィリアムズさんと
Well, in the same way as William did, well, we have the data right here, so I can show you the data. Can I show you the data that I have?
はい、その関係の
So any questions in the meantime? Professor Muso and then Segawa-san.
If Professor Williams made any comment on the lack of appropriate control populations for comparison, the fact that the comparisons are between apples and oranges really, and that there is not an appropriate Japanese cohort for comparison to determine the differences.
He made the comment that he thought that in retrospect it would have been wiser to limit the age to 14, all below the age of 14, which again was the age limit that was used in Chernobyl for children under the age of 15, so up to 14. But I think the design of the study is different. The design is to measure the prevalence in the first round of the screening, and then in the second round to measure the incidence, because you've got a baseline from the previous round. And in my view, I don't know whether he shares it, but one shouldn't really be discussing the results until the second round is completed, because if there is an increase in the second round, then we are probably, that's an increase in the incidence, which is cases that are occurring in the last 2 years, compared with cases that might have occurred up to 19 years earlier, initiated. So we should really wait until the completion of the second round of screening. Then we have the equivalent of a study with a control population.
Length of follow-up in Fukushima is much, much shorter than the length of follow-up at Chernobyl, and it may be that those who develop thyroid cancer after exposure at an early age do so after a longer latent period. Yeah.
Shorter, probably. The first cases occurred just less than 4 years after the exposure. And that's a very short latency.
There's you really need the two-way classification: age at exposure, age at observation, and I don't think either study's probably got that. We probably won't see that from both studies.
No, I mean, it's available from the Chernobyl study, but we haven't got the data. We've only got what Professor Williams has produced, actually in the last few weeks, so very recent data.
Sega-sanと吉田さんから。
Sega-san raised his hand. What about this graph? So looking at the relationship, looking at the Chernobyl data, for the first 4 years after the incident, so that's a distribution for the first 4 years after the incident. Am I right?
6年間ですか。
The first 6 years, not 4 years?
多分津田さんのとこれ見て3年最初の3年
The first 3 years?
After Fukushima, yes. So actually it's doesn't specify the number of years after. I guess it's the total number for the Chernobyl data.
これあと
When you say Chernobyl, it's a big area. Ukraine, Belarus, different areas. Which exactly in Chernobyl was he looking at when he created this chart? Which area of Chernobyl was being addressed?
He's taken the total number. He has the figures for Belarus, Ukraine, and the Russian Federation, and he's probably taking the whole lot together. He doesn't say here.
じゃあ全体について
So spending 3 years and 3 years to 60 years, they look at the entire area, right? Well, the question is, so he was looking at the 3 to 6 years, covering all the areas in Chernobyl.
He
May I?
looking at the distribution, numbers of cases by age at exposure, the highest being the youngest. I'm not sure that it matters how many years that is, because I don't think it changed that much over the period. It was roughly the same. But I think the younger cases came earlier than the later cases.
吉田さんにちょっと
Next, Yoshida-san, and then Tsuda-san, Dr. Tsuda will explain. So I've been researching on Chernobyl. In the detail or so, from 0 to 4, there's the highest case in Belarus. 30% of young children from age 0 to 4, they show the high level of cancer. But as you said earlier, the first group of people was rather older age than those 0 to 4. And in Ukraine and Belarus city and Russia, there's some difference in prevalence among those young people. Well, when people look at the entire picture after quite some time after the incident, based looking at the Williams graph, so that's my understanding. Am I right?
Point that you're making. I mean, I think this is a very clear graph which is showing that there is a difference between the age distribution at exposure between Chernobyl and Fukushima. Now, I don't think it matters whether this is 4 years, 6 years, 10 years. The fact of the matter is that that distribution, which is falling from the very young age, is not the same as the distribution that is occurring in the figures that we have up to 3 years after Fukushima. That's the only point that I think is being made here. That's all. And it's not to say that the situation in Fukushima is not due to radiation-induced cancer. It is just to say that it's not following the pattern that we know was radiation-induced cancer after Chernobyl. That's, I think, all this diagram says.
それはですから今
All right. At this moment of time, pattern is different. So I want to confirm that your message is that pattern is different as far as the available data is concerned. For instance, we have the data of the 4-year follow-up after the Fukushima, and we can say pattern is different, although the follow-up period might be different between this graph and the Fukushima data. Sorry, just verbal argument is not meaningful. Therefore, please take a look at this table. It tells everything. In 1998, Chernobyl happened, and the x-axis horizontally shows the age at the exposure age, and the vertical axis shows the age of diagnosis. And therefore, this table is equivalent to the Williams data, and then up until 1989, 3 years after the accident, 75% of the person who have the onset of the cancer is above 10 years, older than 10 years old. And then in case of Williams, he just shows the aggregated total here, corresponding to this and this table. However, as to Fukushima, up until this point, data is available. And right now, we see the same pattern of the Chernobyl, meaning that we have a higher rate of the children older than 10 years old.
これから
From now on, younger exposure age children may have thyroid cancers. There is the highly likely to see such a situation in the future, and Dr. Tsuda says, yes, it's true. And then the graph of Dr. Williams and the graph derived from Fukushima accident may be overlapped, superimposed. Now you see?
you're talking there about cancers being diagnosed before the 4-year latency period. But you don't know that those were radiation-induced cancers, do you? You don't know that those cancers before 1991 are radiation-induced cancers. There will be a spontaneous yield of cancers in the Chernobyl population. And they may appear sporadically at a very low rate, and that might be the same thing that is being seen, but amplified here by the use of screening. So, I mean, I think that the point that Williams is making is simply that we don't yet have the evidence to assume that there is. He believes there will be an increase, but he doesn't know how big it will be. But we don't yet have the evidence to say that those cancers that were diagnosed by the screening program were radiation-induced. That's all he's saying. We don't have the evidence to say that, and we won't have that evidence until the second round is completed.
それは逆
Conversely speaking, from the opposite side of what you said, is that in 1989, up until 1889, radiation-induced cancer evidence does not exist. And what's available is what I have shown to you, that is in the Looper curve. Statistically, in the following year onward, there are a higher frequency of cancers significantly, and that is the only one evidence available right now. Maybe we do better to have an offline meeting between you and me. I intervene between you. I know. But you shoot up your hand, right? Meaning that you have a say.
I think the angels are on both sides of this debate. To compare Chernobyl and Fukushima, we need to have the length of follow-up matched. And so that slide does show some of that. But the effect of screening is the other thing, which started earlier, relatively, in Fukushima than it did at Chernobyl. Yeah.
いや、わかったわかった。何も言いませんから。はいはい。こんなところで議論したらしょうがない。
Okay, thank you. I agree with Professor Matthews that we need to wait longer, of course. But if we do simple mathematics, if I understand it well, because of course I'm not an expert in these things, incubation period is like 4 years? Minimum, yeah. And given the fact that the highest incidence in Chernobyl is with children who were 1 year old,
yes.
It would mean that in the coming years, from next year on, we could start to see some kind of a rise.
Yes.
So it's just a matter of time, no?
Yes, and they should be seen without screening.
Yes.
はい、どうぞ。
Yes, please, Dr. Tsuda. Even if there's no screening, it's clear that already, even if there were no screening, it's clear that the higher frequency of cancers, and therefore, if Fukushima will see higher frequency than before, it's matter of course, no surprise. I'm a kind of pro Dr. Tsuda. Anyway, many Japanese doctors are more pro Williams. It covers 87 cases, right? 87. And up until 120 cases covered, including second round cases. And that's what Dr. Tsuda mentioned. And the age is younger in the second wave. And then male children incident rate is higher. There are other data that might be confounding factors. And that's why evaluation between you, Dr. Tsuda, and you have some differences, including time lag. The first thing is that within 3 years, there is no onset of cancer. For such people, they didn't take a look at Chernobyl data seriously. Those who say that there's no cancer onset within 3 years after the accident do not take a look at the data of Chernobyl seriously, such as the doctors in Fukushima Medical School and Dr. Williams.
Williams certainly took very seriously all the cases and examined the pathology of all of those cases in the first, say, 10 years. Yeah. Including ones that had occurred in less than 4 years.
But he did not compare the incidents in 1986 or before 1986 and 1987. Incidents of 1987.
Incidents in 1987. Yes.
Clearly increased.
But what he says in this paper is that the mechanism by which he believes that, and this is based on a lot more evidence, the mechanism by which thyroid cancer develops requires more than 1 year to develop because there's an initial slow process, relatively slow process, and very often a tumor will get stuck at that stage, and it needs, he talks of it in terms of mutations, it needs a further mutation before it will start to develop properly towards malignancy. So there may be a lot of these small cancers which don't develop, maybe even disappear, and it may be those that are being detected by the screening program. And that they would, without the screening, they would never be noticed. That's his point.
Williams sensei.
Well, Dr. Williams is not thorough enough because in terms of mechanism, CDC, Center for Disease Control, and Prevention, which you know very well, is saying that based on mechanism, in terms of the pediatric cancer, the smallest, the minimum latency is 1 year. And Dr. Williams is talking about only the average latency. He's not talking about minimum latency. He doesn't talk about minimum latency. And furthermore, putting mechanism aside, the epidemics breakout is taking place in Chernobyl. And in terms of children, so starting 9th month, there were thyroid cancer that were detected at only 9 months after birth. So this idea of latency of 4 to 5 years is not based on evidence. This is just a misconception by Dr. Williams, I believe.
If you plot the total number in Belarus, which is, I can speak for this because this is what I did. If you plot the horizontal axis by the year, so 1989, 90, 91, etc., and the number of cases diagnosed in that year, regardless of age, at diagnosis, that line going up for about 8 years is a straight line, very straight incline, and it intersects that baseline axis at about the midpoint of 1989. That suggests that that's the minimum latency for the disease as it is being diagnosed. And I would say that 90% of those cases were radiation induced.
でも実際はこういうふうに起こってきてるわけです。
But the reality looks like this graph here, which happens that right after 1 year, there is a statistical significant breakout.
Those are not the figures that I plotted, because actually, well, you don't go far enough. You're going to 93. When I plotted them, they were the figures that were collected just from the Gomel region of Belarus, and they were up to, I think, 96. And it was a straight line coming down. I haven't got a graph of it, I never published it, but it gave 3.5 years as the average latency. I can only say that's the data that I have.
But not the minimum.
Well, I don't know. The minimum latency there might have been a sporadic yield of cases before 89, but they weren't on that line. That's all I'm saying.
いや、ちょっと待ってください。
Please wait a moment because I'd like to continue my argument. When you talk about straight line, you're talking about estimated straight line, assumed straight line. But what is actually observed is this line here, this graph here. And this same curve has been observed in Ukraine as well. Dr. Williams, Dr. Weberstock, and Dr. Tsuda are having a very heated argument right now, but there are observers in the sidelines, so let us hear their comments. Perhaps Kageura-san, Watanabe-san. I am Koichi Watanabe. I specialize in art. I teach at Fukushima University. I focus on anatomy, and I teach art anatomy at the FMU, and I also teach arts in the Fukushima University. I participated in yesterday's session in between arts and science. I have some artwork here presented here at this venue. I said yesterday as well, when we talk about the relationship between arts and science, oftentimes people talk about myths, but if we look at the future, if we base ourselves on the past data and try to extrapolate the future and try to come up with some kind of countermeasures or measures for the future, I think that's in a way what art is. The current controversy, I think controversy is very important, so I think you should continue your argument later on. But however, when you think about and when you extrapolate about the future and when we're trying to come up with some kind of solutions and countermeasures, isn't there anything that science can do? Science can do? But, well, I have other questions as well. Another question I have is, and maybe this is in relation somewhat with the millisievert discussions. Well, for example, if you ride a car at 100 km per hour, it's dangerous. You might get into an accident. The same goes. That's why you have the road, the codes, in order to mitigate such accidents. And I think that kind of similar rules and codes can be suggested from the science field to the society. And additionally, when it comes to the data that we are talking about now, for example, there are so many students at Fukushima University, FMU. There are the local citizens in Fukushima, and on the other hand, there is this data here that we are debating about, but can we really talk about these two different elements exactly in the same way, as if it's the same reality? Well, one concrete measure is the PET screening. We were talking about CT scan, so PET. Well, the PET screening device only exists actually in Fukushima. There's only one device, and in a way, It is extremely hard currently to screen our physical condition in Fukushima even today after the accident. So in that sense, from science field, from the scientific experts, can't we come up with more concrete measures and solutions? I actually, from artist's point of view, perhaps I would like to have more concrete suggestions from the scientists of what we could do. I wanted to comment about two things. First of all, Watanabe-san talked about scientists proposing some countermeasures concerning risk. I think that is possible because risk is not based on science. So I don't think if the citizens and the general public have such expectations on science, I think that is not possible. And that, and also another point, I'd like to clarify one point about the argument earlier because I kind of felt left behind. So let us just confirm about the starting point of your discussion. First of all, Dr. Williams' graph, where is it and what time period? What is the basis? What was the comparison base? How was it compared? What was the methodology? Can we really compare this with what's going on in Fukushima? Can you just go back to the basics and talk about Dr. Williams' results, please?
I think I share the view that Dr. Williams has, that what was initially set out was to screen the potentially affected population, that is people below the age of 19 at the time of the accident, to see if there was an increase in thyroid cancer. They chose to use a very sensitive screening technique, much more sensitive than has been used before. And secondly, they chose an age group which included children over the age of 10, when the incidence of thyroid cancer starts to rise as they become adults. So the results that were obtained in the first round were really the prevalence. That is, the cancers that were in the population or growing in the population from even before the accident, you don't know how many of those were induced after the accident or how many of those came before the accident. So to get over that problem, there were two possibilities. One was to go to somewhere else in Japan where there was no exposure, choose a similar number of people as a control group and screen them. That they considered was expensive because really what they wanted was the incidence in the first 4 years as a kind of baseline, I think, because they had the expectation that there wouldn't be a radiation-induced increase, or at least a very big one, on the basis of the Chernobyl experience in that first 4 years. So they could do 2 rounds of screening in that 4 years, and in the second round, which is not yet complete, they would find out the incident cases that had occurred in the 2 years before the screening. And that, if those were increased, that would be an indication of a radiation-induced effect. So Williams doesn't rule out a radiation-induced effect. He just believes that by looking at the partial data, which is less than the second round of screening, it's not complete yet, one can be led to conclusions which may not be valid in the long run. So all he is really saying is, if we look at the experience that we had from Chernobyl, does it match what, because these cases are a surprise. These cases that have been detected by the screening in the first round are much higher, as he points out, than could be expected normally. And he doesn't know the reason for that, but he doesn't think that it is necessarily the radiation. That's all he's saying. The situation will be resolved when the second round is complete and we know the results for the complete second round screening. Does that clarify it for you?
The point is partial data, and also it's just a hypothesis from the comparison on the basis of partly partial data. So I think, thank you very much for the clarification. I think Tsuda Sensei also has a say. So I guess we sort of shared a bit of background to sort of catch up with the heated debate. Thank you very much.
ムソ先生も
So any comments from Dr. Muso and Tsuda Sensei later?
I would just like to ask Dr. Matthews his opinion as to the best study design at this point to address the question. If you had the resources, how would you design the most sensitive study possible, given that the results do seem to be different than what we see in Chernobyl?
Well, I guess you'd do both. You'd do what Dr. Baverstock suggests, and you'd have the second wave to look at the incidence of new cases, and you would also ideally have an unexposed control population. But you'd have to choose that carefully, because those who know about thyroids, things like the amount of fish that people eat would be important, and so on and so forth, because presumably a lot of the thyroid effect is due to the uptake of radioiodine early, and the amount of radioiodine you take into your thyroid depends on how much you're eating in your diet of normal iodine beforehand. So, there are lots of complications about trying to get a controlled population.
じゃあ、はい。そうですか。じゃあ津田さん、その後。
津田さん and so prior as I showed in my slides, prior to the Chernobyl accident, compared to the data, so there was an increase in 1987 in Belarus city or Ukraine. The same thing was observed. Okay. This is not my plotting, my own data. And also I would like to say that in Chernobyl, with the almost no exposed people, 35,000 people who are not exposed, or 70,000 people are investigated or researched on through the screening in the same way. And there, for example, if you look at the bottom of this chart, those two, 35,000, no one has the thyroid cancer. So that's an unexposed group. We did screening, of course.
What's going on in the Chernobyl areas
いや、これは
1996.
これだからスクリーニングしてるんです。
Well, they did screening from 2002. So 1998 to 2000, in an unexpected group, there was no one who had a thyroid cancer in 35,000 people.
But comparing people probably with a degree of goiter against a Japanese population with a very high iodine content in the thyroid and a much smaller thyroid. So I don't know that you would necessarily expect to see the same thing in those two populations. But I'm not a thyroidologist, and what I may say is that your argument is really with Professor Williams, not with me. I'm trying to present the view that he is saying that there is no direct comparison to Chernobyl. With the figures that are available from the Fukushima screening. I am saying that this is a partially completed survey the second round of which needs to be completed, and I, as a scientist, would not wish to draw conclusions from a partially completed study. That's all.
いや、まだあります。はい。
Well, in the second round, we have seen the significant instance of thyroid. Even there's no thyroid detected after the second round, or in the second round, still we have 20 times as many cases of thyroid cancer as we could have. So, to answer William's questions, I can answer all the questions. I can just ask him to communicate in writing. I can answer his questions in writing.
I'll give you William's paper, and you can write to him. Yeah.
Forgive me my ignorance eventually, but can we summarize from a societal perspective, can we summarize this discussion as saying that right now Dr. Tsuda claims that we can already see an indication of radiation-induced thyroid cancer with children, while Professor Williams says you cannot see that indication yet.
Yes.
Is it that?
Yes.
So there is no disagreement in a way, as simply too early to really see more evidence.
はい。まとめて。
So there's a request to sum up the discussion. So Dr. Matthews says a few words.
I was just going to ask a question that maybe someone could answer. The iodine that would have triggered the cancer will have disappeared long ago, but has anyone looked at radioactive cesium levels in thyroid cancer cases? Because if you contaminated with one isotope early on, you might pick it up later with another one that's more long-lived. Does anyone know if that's been done or whether it's worthwhile?
I doubt that it would be worthwhile, because the huge amount of uptake of of iodine, but radioactive iodine if it's radioactive, by the thyroid is sort of so much greater than the uptake of other nuclides. So I don't think that there would be a measurable amount of cesium necessarily. It may be there, but it wouldn't tell you very much. It would be very insensitive if it was there. So the dose really comes from the fact that the thyroid absorbs iodine very, very effectively. Yeah.
But at least if it told you that they were more exposed than those who hadn't got, that's the basic point.
I think the problem is that we don't know the extent of the exposure very well. It's very difficult because it's all gone within a month, and unless you do a lot of individual thyroid measurements, as was done after Chernobyl, the dosimetry is very poor, and I think relatively few thyroid measurements were done after the Fukushima accident.
Yes, I'm not referring just to thyroid. I'm just saying that a general measure of exposure, which was longer lasting, might tell you that this particular person had a greater exposure to fallout or contamination than a person who didn't get thyroid cancer. That was all.
Well, the big weakness of the dosimetry after Fukushima is that we know very little about the doses in the first, say, 4 or 5 days. And there could be people highly exposed, but where we have measurements, for example, in Fukushima City, the doses don't appear to be that high. But then we're talking about the evacuated populations, and we really have no idea about their doses until, before they were removed.
Yeah, I mean, it would be reasonably expensive, but it might just be worthwhile testing a handful of people for total body burdens of cesium, if it hasn't already been done.
I know. it will mostly have gone. I mean, it's 100 days or something, half-life. No, it's about.
Please use the microphone.
はい。これはまあ、いくらでも。
We can keep going on and on and on and on. I know. Dr. Tsuda, can you please behave yourself? Because we need to summarize and conclude the session. Environmental epidemiology area. In this area, individual dose exposure, in this case, exposure dose, is not necessarily because without the accurate dose level, we can see that is a non-referential dose classification or instrumental variables. This concept can be introduced. To begin with, if we know the precise measurement in the environmental epidemiology, there's no such paper at all because it's impossible to measure the past dose level, whether it's arsenic or the air pollution or smoking quantity. There's no such data. In the area of radiation alone requires very precise exposure level or dose. The second thing I'd like to refer is, please take a look at this. And the second round, you see the huge increase of cancer. The latest one is 55 times more. In Fukushima, 27 folds more. And at the Nihon Matsuri, 16 times more. The more we get the information, the more we see the higher frequency. And the second round is higher than the first round. In addition to that, on the assumption that the remaining people who are yet to go through screening excluded, still this high level of frequency. That's why we get the already answer to the Williams paper. Another thing, just one thing. In Chernobyl, insufficiency of iodine is not a problem because in the area with the iodine sufficiency area has seen the higher frequency because the insufficiency of iodine can increase the thyroid cancer. This is not referred in any medical textbooks at all, and therefore this is just an idea of Dr. Williams. As Mr. Iwata proposed, there may be the further development between Dr. Tsuda Williams' arguments and wait and see how it will develop. Because this is quite a significant issue with many aspects entailed. However, at this moment of time, it's very difficult to pursue technical issues, and therefore, I'd like to move on to the next topic. We have prepared two topics. One of them is the psychosocial impact and the community people. They are forced in the environment where they cannot speak out anything. In addition to that, they suffer from the decontamination work and the first floor of Fukushima NPP or so-called F1. Psychologically, they suffer quite a lot. There's a huge alignment because of the fear of radiation that may damage the health, according to some research paper. That is the current situation, and therefore, how should we argue and discuss this issue? This is the first topic of the two. And then, as to the effect of the radiation, the government side, or I would say experts, tells that there's only one issue, that is the increase of cancer. In addition to that, after the Chernobyl,
only the thyroid cancer has seen the increase, and therefore non-cancer diseases are out of the subject of any studies and researches, and that is the overall direction of the government. And therefore, how should we take this issue? For example, if you look at thyroid cancer, already non-thyroid cancer symptoms and problems may happen at higher frequency according to some people, or in other cases, in hematology examination. A certain sign can be detected. However, there is no structure or organization to look into those potential abnormalities for non-thyroid cancers. Although we have about 1 hour, but maybe we can have a discussion. So I raise 2 topics. Either topic is all right, because both of them are very important. Therefore, can you please share your in-depth insights?
Issue of psychosocial effect and the issue of the impact other than cancer. Dr. Sakiyama, perhaps? Well, I would like to answer about the second question regarding non-cancer effects. In Chernobyl as well, there has been many reports of non-cancer abnormalities. And in the UNSCARE report, well, the favorite of Dr. Nagataki, by the way, even in the UNSCARE report, in the 2006 version, that is, there is over 100 pages of mentions regarding immunodeficiencies and immune abnormalities as a result of radiation, and various evidences has been mentioned in this report. And also, regarding the reports and the data from NIRS on Hiroshima and Nagasaki, there is clearly a report about the same. And additionally, regarding the blood and diseases, is there any radiation impact and linear increase of blood abnormalities? Well, yes, there are such reports of linear increase in line with the dose increase. So talking only about thyroid cancer is not normal, and that is something that is already discussed after the result of Hiroshima and Nagasaki. The fact that there is a cancer incidence, it doesn't mean that it is impacting only one DNA. The fact that there are various mutations and changes to the DNA, it shows that there are various defects that are caused on various cells in human body, which means that there are it's quite ordinary and natural to think and that there are other abnormalities and deficiencies in the terms of the physical effect other than cancer. Especially the lymphatic system is extremely prone and sensitive to radiation. That is very well known. So 100 millisievert is already dose level that could cause the sperm death and also the cell death of lymphatic system. We should not ignore these facts. And even in Chernobyl, the fact that there is a high incidence of thyroid cancer is, well, as Yamashita-san himself mentions in his paper, there is a particular reason why there are such high incidence of thyroid cancer in Chernobyl. And when we talk about the thyroid abnormalities, especially Hashimoto disease and autoimmune disease, could be increasing in the Fukushima area as well in the future. Well, it's hard to have self-detection, so the patient would have to go through blood screening, for example, to be detected. But in any case, we need to keep in mind that there is a possibility that such diseases and abnormalities might increase in the future, and we need to follow up. I see hands being raised. My name is Tajima. In relation to what Dr. Sakiyama said, and on the 31st of August, the FMS, the Fukushima Health Survey Committee meeting took place. I was there listening to the discussion, so let me talk about my impression and cite two numbers, two figures. Well, the two figures that I still remember is, well, first of all, the number is 138. The possible suspect malignant thyroid tumor. That's the number of cases, 138. And the second number, well, in the first round, we had A1, A2, and B2, and certain children who were considered to be B go through the second round examination, and they still got B. And that is 1,845 cases were children who were diagnosed as B in the both first and the second screening. So these were symbolic numbers. Within 138 children, it includes one patient who were actually operated, and it was not a malignant cancer, but a tumor, but it was benign. But then, this is not a happy result for that one patient who had a benign tumor, because it had a tumor, the child had a tumor, it is a disease. And also for the 1,845 children who had two diagnoses of B results for the first and the second round. Well, these children were all diagnosed with nodes, the thyroid nodes. And this is also disease, and this is also abnormalities that the media and the newspaper don't talk about. But when you look at the committee's report in Fukushima, but these children are covered by insurance, even if they grow up and become an adult over 20 years old. All the medical expenses that are incurred will be covered fully by the government. And in that sense, that is acknowledged by the government. And this is a great change that has taken place in Japan. But strangely, this is not being debated, and this is not being talked about by the media or the newspaper. And this suggests that there are other thyroid abnormalities than thyroid cancer. So what are the abnormalities? What are the thyroid diseases? Well, that is not talked about or reported yet. So once the patient goes to the hospital and once there is a diagnosis, they have to report themselves to the prefecture. That's impossible. So in that sense, when we talk about non-cancer diseases, the information needs to be released and be open. And in that sense, we need the residents' organization. So the prefecture, Fukushima prefecture, is saying that they are willing to support, and there's a brochure which says that if there is a possibility of cancer among children, we will support. That is crazy. They are talking about these children who are diagnosed on the first round as B, but then they were negative, so they did not go through fine needle aspiration. So in that sense, they're right. They do have a right to claim medical expenses, but they might not even claim this right themselves in the future. And talking about these children who don't have cancer, we need to look at and understand the details of these children so that we can follow up. That's what I wanted to say. The children who have cancer, well, it's 1 in 2,000 if you undertake 2,200, 1 in 2,200. And for the thyroid, it's 1 in 180. That's the current number. So as we have these numbers, we will have similarly a very accurate number for non-cancer thyroid abnormalities and diseases as well. So that's what we need. Please go ahead. Well, this is the paper that was featured on the magazine called Thyroid. Dr. Yamashita is a co-author. Look at this graph, please. This is from 1995. This part is cancer, and this part is non-cancer, but thyroid abnormalities or diseases that are non-cancer. And right here, these are this is a radiographical area where which is used as a control group because there was a low level of radiation. So in that sense, you can see there is an increase here comparatively. So in that sense, there is an increase of non-cancer diseases compared to the control area. That's what the paper says. Of course, the cancer is also increasing, however. So even in a low radiation dosage area, they did not detect. Well, I already repeated this part of the fact earlier on. That's all. So Yoshida-san, please.
Other than cancer, so everyone agrees that we should check on other than cancer for possible detection. This is Russians' research on children. So in 2001, there's a symposium, and that's a record of the media convention in 2001. So there are reports from different regions. So a lot of topics are focusing on thyroid cancer, but there are other areas than Chernobyl to talk about non-thyroid cancers. So the report was made on other than thyroid cancers. So in Chernobyl, there is a registration within different hospitals to do registration of people who are exposed, and they compare the prevalence against the national prevalence. And there are various types of diseases which they identified in Ukraine and Belarus and Russia. So they have seen the other than thyroid cancers. To protect children's health, of course, you have to detect if it's related to radioactivity or not. But the most important thing is to detect the children for treatment and prevention. So long time ago, Dr. Nagasaki said that in the culture of radioactivity in Chernobyl, why they can't, there's no acknowledgement of the non-thyroid cancer because there's no information about the dose. So there's no relationship identified between the radioactivity versus the other than thyroid cancer, as Mr. Satyama said earlier. So we have seen other than cancer identified. So everyone feels the same way, but the people just tend to focus on only thyroid cancer. That's a problem. Well, that's related to Japanese government or the Fukushima government policy. But we have to have a wider look at the other possible diseases to protect the people's health, not just focusing on thyroid cancer. You talk about the wider coverage of the screening. Well, as a physical disease, other than the thyroid cancer, we have to look at other possible diseases. Well, people take it for granted. I have some questions to clarify age. Well, we're talking about the younger age. What about the adults for thyroid cancer? This is about the psychosocial effects in this section. So in the good health, other than thyroid cancer, we haven't seen other than thyroid cancer. What about the social psycho effects? WHO Charter says that they have the definition of health. So health doesn't mean people are not sick, or in physically or mentally or socially, people can be active. So if we look at the psychosocial effects, we just look at the health condition itself, then we can expand the scope of what we have to detect. We have to have the same understanding of what is health, what is well, that has to be understood commonly among participants. I have some comments to make. I'll cover the details tomorrow. So Dr. Tsujiyoshi in May, who is a professor at Waseda University, he researched on 16,000 people for about the evacuation, and more than 40 people suffered PTSD. So there's a possible PTSD. So the doctor identified that there's a fear of death due to nuclear accident. So typically PTSD is related to day-to-day concerns or fears, but in this nuclear situation, so this type of PTSD is related to death. The government set the time frame long time ago. Dr. Kageura said that we can't define the risks scientifically. Well, danger can be translated into risks, but in general speaking, danger cannot be defined. Well, I was talking about the danger in a general sense. I wrote the articles. I won't go into the details, spend a long hour time, but I'll talk about this for the non-Japanese people. To take a risk, using a psychologist, we invite people who have been evacuated and they conduct a workshop inviting children and their friends from Fukushima primary schools. Throughout the workshop, they made the Japanese curry. And when they create curry, and this carrot was produced by your mother's field, or those carrots and those products were produced in these rich local areas. And children started to feel there's a strong connection between them and their local areas. And also they remember strong connection between children staying in the area and also children who are evacuated. So for those children who are evacuated, and when they came home to meet their mothers, then ask when can we go back to their hometown. So that made children feel like they want to go back to where they were born and raised from the evacuation area. Well, I agree that citizens' participation is important and this is necessary. But in our society, in our situation, how can we how can we tell how much liberty, freedom we have to make a decision as to what kind of moves we can make? My name is Kawane. Sujiro-san mentioned that what kind of impact would be there for adults, not just on children. In Belarusi, do you have any number of incidents in cancer for adults and children? And I'd like to take a look at it. More than the incidence of cancer, there's a significant more increase in cancer for adults 8 years after the nuclear incident. There is a 3 times increase of the thyroid cancer among adults.
In 1986, the adult incidence rate of thyroid cancer is about 140. And then 6 years or 8 years after that, in 1990, it's more than 550. And then there's a surge of the child thyroid cancer. However, what's more problematic is adult thyroid cancer. There's a specialist at the Ito Hospital in Tokyo. There were 20 to 30 experts, and if you want to get the treatment by these experts, you have to wait for 2 to 3 years to treat your thyroid cancer. And then screening was not conducted in Chernobyl accident. However, the Dr. Shunichi Yamashita made the report, issued the report about Chernobyl, as you see here. This is excerpt from the Sasagawa Foundation. It's prohibited to copy and paste, and therefore I just copied the text from that website. And this shows the result of the screening at the Chernobyl, the accident in 1991. 5 years after the accident, there was the Dr. Yamashita, and how many people were screened? Belarus 2 areas, Russian Federation 2 areas, and then 160,000 people were screened in 5 years after the accident. Not only thyroid cancer, but hematology checkup was conducted too. Ukraine has two regions in Belarus and 1 region in the Russian Federation at the center, and in total of 160,000 children were screened and examined, and therefore whole body counter to measure the dose was conducted, ultrasound measurement was conducted, and the 3 parameters of hematology examination was checked. In 1990 and 1991, as you've heard, the incidence rate of thyroid cancer increased suddenly, and I believe that this is a screening effect conducted by Dr. Yamashita, because unknown cancers were detected in this screening, and the similar thing was conducted immediately after the Fukushima accident, and therefore it's no surprise to detect the thyroid cancer from the very beginning. No wonder, for example, the thyroid abnormalities confirmed in the thyroid cancer screening, such as the nodules cancer, the thyroid hypothyroidosis. No sound feed. No sound feed, Iwata-san. So please take a look at description. Page 26. It shows the acute lymphatic leukemia girl. exposure age is 1 year old and the 10.5 years when the diagnosis was made, and the tumor size is 5 millimeters, and you can see the subtype of the leukemia, and the description says that 4 cases of leukemia were all cases when the exposure happened below 2 years, and 7 years to 10 years latency existed. That is a description in the report conducted by the Dr. Yamashita, dispatched from the Sasagawa Foundation. So everything was known. So this screening as well as other parameter checkup was conducted.
Clarify some points. Yes, there will be leukemias following the exposure from Fukushima. And there will be children will have a higher sensitivity. As for the adult thyroid cancer, or in almost any population that has not got an awareness of the possibility of thyroid disease, you can increase the incidence of the disease just by people looking for it, palpating it even themselves. But if you use screening, you will find it. And I think it's the case that in South Korea, it is routine to screen adults for some years now for thyroid cancer, and the incidence rates have gone up there quite dramatically. It's also a situation in Finland where we don't know quite what the reason is, but the incidence rates of thyroid cancer amongst middle-aged people, so people 30 to 60, is some 10 times higher than it is, for example, in Norway. So these thyroid disease is easy. I mean, probably there are people in this room who could be diagnosed with thyroid cancer if they went for screening. But they probably will not see any result of this. And this is where the over-diagnosis problem comes. Because operations are performed, they lead to dependence on drugs for the remainder of their lives. And it's probable that those cancers would never have come to full malignancy, and they wouldn't have even been diagnosed if there wasn't an awareness of the situation. So I think we have to be very careful, because the psychosocial effect is really to do with the fear that people have that something might be terribly wrong and it's being hidden from them. And I think that the evidence is fairly well evaluated. I'm not saying that there are no increases in adult thyroid cancer, but it's much less than for the young children. Yes, cancers, solid cancers, and leukemia will occur at the doses reported, for example, by the WHO, and they acknowledge that. That is the situation that one lives with. But there's also cancer, I'm sure, being caused by natural background radiation. And there are the cancers around nuclear power stations being caused by tritium, probably. Slowly we are learning about these things. There are risks associated with exposure to ionizing radiation. The thing is, people have the right to know what those risks are and to make their decisions, for example, if they are returning to a region that's contaminated. They should know precisely what the risk is, as far as we can tell them, going back to live there. If they think that's fine, then they should go back there. But if they think that's not a risk that they should take, then there has to be another solution.
You referred to psychosocial effect For example, from the Fukushima Medical School has presented some ideas on that. Unnecessary worry had huge damage. In addition to that, health impact from radiation has a deluge of information, and the meticulous research on that may have a negative impact according to the report from the Fukushima Medical School, and that's why proactive research on the psychology was conducted with huge money invested, I assume. However, what do you think about these issues? Yes, please. 2 people, one by one person at a time, please. I didn't expect I was allowed to speak up. To be frank with you, I have too many things to say. First of all, Dr. Watanabe mentioned there's the action we can take on one side, and there's a science on the other. At any rate, what's important is that we have to do what we can do as an action, whether it's at the government level or at the scientific level. We have to be able to see the attitude that someone is working very hard to take any actions, and I believe that is alleviate psychological burden. Dr. Yamashita knew everything because the NISA, he's a chair of the nuclear committee of the NISA, and he recommended that we had to make people intake the iodine or iod after the accident, and that Dr. Yamashita heads up all of the research and studies, and therefore he is responsible for the increase of the thyroid cancer, if any, although he does not assume the position as a full-time researcher. However, still he is a co-chair of that committee. And then there is a different school of Nagasaki University, and this different school of ideas remains, and we have to try to change these fractions of the ideas.
And other than that, in terms of concrete measures or countermeasures, well, maybe it was not talked about yesterday, but we already know that decontamination does not help reduce the radiation dose. And when evacuees return, well, we were talking. Someone said figures are too political. But the thing is, if the evacuees can return to a place where the radiation dose is lower than where they are currently on, that is okay. But if that is not the case, if they're returning to an area where the radiation dose is actually higher than where they are currently are, then that should not be undertaken as the decision of the administration and the government. If you go to an area with low radiation dose, then the people would be exposed less, obviously. So what is most important is to really think about where people are, where population reside. This should be the perspective of the government. For example, the citizens registry, resident registry, there are double registry of people who have the registry where they were born and people who have the registry where they currently reside. Actually, it's a good idea for Japan overall, not just for the nuclear, because there's earthquake, there's tsunami, there's other natural disasters in Japan. It's good to have 2 registry where people can reside in 2 options. There are so many actually options when in terms of what authorities can do. This is not just decontamination. There are other measures we could do. That's the proposition we need to undertake. We need to talk about different options, and we need to think about what could be the measures or countermeasures where we can undertake more easily without with least stress. Listening to his comment, I kind of forgot what I wanted to say. I also have a lot I would like to comment about, but I'd like to be very brief as well. Up until now, the discussions, I think, was meaningful. And what I felt was that clarifying causality is one exercise we are undertaking. And at the same time, there is another objective of protecting public health. There are relations, but at the same time, we need to think about these as a separate elements. Once we clarify the causality, and taking the countermeasures after clarifying the causality, well, that's too late. From the public health perspective. And going to back to the subject of the psychosocial effects, well, there is a lack of debate, and that is creating certain psychosocial effect currently. What the FMU is doing and what the MOE, the Ministry of Environment, is doing in terms of the risk communication advocacy, well, that is actually worsening the psychosocial effect in the society, I believe. And because on the basis there is the initial creation of the lack of trust and confidence that was created at the initial crisis, and no one knows who's saying the truth, to what extent there are truths. No one knows that, and so that is why the people, so-called experts, the fact that experts have different views and opinions, and the fact that they undertake public and open debate, that can be necessary. I believe that is necessary in order to fill the gap of the lack of trust that we currently see. And on the other hand, however, when we look at the government side and when we look at the FMU, they think that the risk communication is the best countermeasure, the priority countermeasure. And their risk communication is that this radiation dose does not have much health effect. That's the risk communication they are undertaking. Well, at least they are indicating that. That is why that's, in a way, the kind of lectures and seminars that they are undertaking in different parts of Japan. Recently, they have doctors, medical experts, and recently even priests who are invited to speak at these lectures. That's where the budget is spent currently. I believe people here don't feel that way, but when we look at the people who are actually living in Fukushima, they are exposed to such pressure of that kind of thinking, and that is why maybe they don't get into a discussion, or the situation is making it difficult for them to talk about what could be the countermeasure, because there are dangers, there are risks. Can we talk about this a bit, please? Aihara-san, as a journalist, and perhaps some participants, representative from Happy Island, can talk about this as well from the local perspective. How about Aihara-san? I need some time to think. Please use the microphone. Anyone from the local residents representative? Excuse me, I was suddenly asked to speak. Risk communication situation in Fukushima. Where can I begin? Because there's so much topics, there's so much risk communication efforts undertaken in Fukushima. Let me give you some easily understand example. Well, recently we were talking about the school meal issue. In school meals, in terms of the safety of the food that they give to the children, they seem as if it is given that the food that they serve to the children are safe. Well, there are so many examples, so many examples. I didn't have time to think about the best example to talk to you about. I'm sorry. Well, I would like to just clarify the debate that had taken place so far regarding FMU and the risk communication. Risk communication started in November of Heisei 23, so that's, I think, 4 years ago. That was the people's kind of counseling room where people can go to talk about their health concerns. And that was set up in that November of that year, 4 years ago in Fukushima. And they eventually asked the people who visit there whether they are worried about radiation or not. And that results were reported to FMU. These were the individual case-by-case efforts that started. And last year in fall, in the autumn, there were the public sessions and seminars started where they incited people to talk more about their health concerns. And the association, the medical associations in Fukushima actually come up with a concrete measure of undertaking these kind of seminars such and such number of times per year. And so they were kind of contracted or to undertake these kind of seminars. So that's what has been happening in terms of the risk communication efforts, at least when it involves the doctors locally. My name is Aihara. Again, I'm a journalist. Risk communication, well, you said that there were so many cases of risk communication efforts in Fukushima. It's true because it's really everywhere on their daily lives. Risk communication, the so-called quote-unquote risk communication, is everywhere in Fukushima. The residents of Fukushima are not able to talk about what they want to say. They cannot really say what they feel. If they do, then that creates gaps and problems in terms of personal relationship among themselves, where they start attacking themselves, so they feel like they can't talk about what they want to say. That's something that I would like to talk a bit more in tomorrow's presentation. But in any case, what is risk communication? As long as I know from my reports, there are experts. The experts come to Fukushima and they decide what risks are. They say risks are so and so. So in that sense, the residents, the participants wanted to talk about their awareness of risks and dangers. They want to be heard. That's the primordial needs. But instead, in these seminars, the experts talk about these are the risks, and they are, well, they try to persuade these participants. So that is why they feel even more that they can't talk about what they are really feeling. That's the emotional conflict that is happening among the Fukushima residents. The people, Fukushima representatives who come to these kind of symposiums and who make comments, that's very much different from the reality of what people talk about in Fukushima among themselves. I would like to comment a bit more about this tomorrow in more concrete ways.
As for risk communication, if I am asked to talk about that, as I have said, well, there are so many things I can talk about in relation to risk communication. For example, while watching TV, well, there is a supporting commercial to support the farmers. So even we are concerned, we can't really voice ourselves. If we raise a concern, then that will attack the farmers in Fukushima, for example. But most people feel concerned to some extent. They can't express their concerns honestly. And even they are told that they can flee to choose. If they're concerned, then don't eat. If they want to leave their hometown, then they can leave. So they are put in such a situation, and they have to make a choice for everything. So that causes them feel angry. And we don't think it's right for us to have to make all the choices in such situation. So attending such session, we have to learn, and then we have to talk to you in this settings. And I would like to deepen our understanding. We have to have such opportunities. I don't think that's right because we are forced to be in such situation. We have to learn from these meetings. We have to try to find a way to have our own life. I'll make it short. I don't know if you remember, in 2013, there is a radiation risk communication done. Well, there was a huge budget secured by the Japanese government for the risk communication in 2013. The budget was allocated to different ministries within the central government, Ministry of Education to Ministry of Labor. So all the ministry received a budget for risk communication. It's not that there's no discussion about risks, but let me say this again. Well, I don't know what to say. People think that risk is something that we can measure, and the government offers to manage the risks for the local people. That's the story that the government has. Well, I think we have to start talking. So the question is how we can define a risk. Like I said earlier, should we take some risks? We are aware that there are risks, but it's up to us to decide what kind of risks we can take as acceptable. Well, I'm hoping that we can have a discussion on a level of risks that the people have to take. As you see here, this is one of the presentations that I used. One of the first ones. This is the one information on the Ministry of Fishery, and then firstly, this is risk communication principles. Those things have not been done in Fukushima, or things are done against those principles actually. So the problematic information from the website has been deleted once people start to think this is not appropriate. So please download this information as soon as possible before the government delete the information. And next, are you going to go into the details of the slide, or are you just showing it? As Bliss said earlier, we can't see the slide. Oh, it's not on the slide? Nope. So how can I connect my PC to the slide itself? I don't know how to do it. About a year ago, so there was an initiative package was introduced by the central government, including the Ministry of Consumers and also Rehabilitation Recovery, and also all the other ministries. They started to do a risk communication. So we're at the stage where we have started the risk communication finally. And the plan was laid out about a year ago. So it's too big. Through the participatory program, they are trying to do risk management, one-on-one or group discussion, and along with the specialists, local people will share their concern about the health. and they would like to offer a more customized and detailed risk communication to individual people. This is example of Iidate village. Maybe Nakagawa-san has been involved in this. I don't know the details. And the small group-based risk communication or the lecture-based risk communication in Kyoto or Buddhism, using the Buddhist temple system, we educate priests to disseminate the information through the temple network. And that's one of the plans but done by the government. I have a question to Aihara-san. So, isn't there any seminar inviting Fukushima media people for educational training? Well, since I'm a freelance journalist, well, there's a journalist society that's very typical for Japanese society. So Main Street journalists has their room available for free of charge within the Fukushima prefecture, and they have a free parking available. So those major media journalists receive information directly from Fukushima prefecture. That's a very Japanese way of receiving information from the local government. Through such a journalist association, well, there are official study sessions, or within the Fukushima Japanese Inn, they have informal study sessions as well, over drinks and dinner. Well, there are varieties of seminars or study sessions, and communication has been promoted. So I don't know who is the key person to initiate such seminars and who is leading the decision-making process. But it's a typical information exchange session. So even before the Fukushima incident and after the incident, there has been a constant of information exchange sessions. But it's hard for general people to see what's going on with the media in Fukushima. So in 1944, there's a novel titled 1984, and that big novel describes the situation like Fukushima situation. So people's sense of liberty has been violated in a novel, and the same situation is going on in Fukushima. So Sebastian raised his hand. So when I hear about the risk communication, I feel very concerned and I feel offended, actually. Of course, there are people who are concerned and they can't talk about their concerns, and that makes people feel sick. And I think I understand the situation, and also we understand that we have to help those people. In Germany, people around the nuclear facilities, there's a specialist in risk communication to talk to the local people around the facilities.
So there's a risk communication experts for the host communities. For example, suppose there's a huge problem and NPP In such area, maybe the president or director of the NPP is the problem, and therefore that the president would be fired. Instead of the president, the communication expert would assume the position of the head of the NPP, and that kind of situation happened in Germany.
Solche Zeichnungen zu entwerfen. Professor Zuler hat gestern sowas gezeigt, diese dreieckigen Bilder, wo so gezeigt wurde, wie die verschiedenen Sorten von Radioaktivität im Prinzip harmlos sind. Ja?
Risk, fear, anything related to risk are not discussed. That's not a problem. Rather than that, the drawing is the schematics such as triangles and circles to tell people that the risk is low. Politics and the industry go hand in hand to prevent usual people from thinking logically and reasonably, and in order to put the general public in the dark, so-called communication expert is used, in my view. And therefore, the topic of risk communication, what is the subject? We have to, first of all, define the target of the topic, about what we are talking about when we want to talk about risk communication, because risk communication is a really vague concept. It's really pessimistic. And I feel today's meeting will end in a very pessimistic mood. I'm sorry about it. And the two people, and Vevastoksan and you, 3 people, and after that, so 3 people come first, followed by the summary of Dr. Vevastok. Risk communication, in short, can be used politically. That is a danger. Actually, in Fukushima, there's a gag. There's the breathing problem, and there are many people criticized about this accident. For example, the problem of the MHW is the vaccine of cervical cancer. This vaccine can cause many symptoms and problems, and the official position of the ministry is the impact or effect psychologically and physically. They intentionally insert the word psychological, just like an BP accident, because of the psychological effect. The cervical cancer negative impact happens. Actually, with the cervical cancer vaccine, some people are in a very dire situation, and some of them are bedridden. Remember what happened to Minamata, mercury disease. They are victims, however, they were criticized being stolen their stones. And this Minamata situation is quite similar to Fukushima situation, because nobody can speak up the fact. That is my worry. I have a say about risk communication, but for you, Vevastok, I want you to consider this. That is, thyroid cancer in Korea increases. And you said that this is the signature example of a screening effect. However, in Korea, there are many medical radiation, such as thermography. In addition to that, the aesthetic plastic procedure is very popular, not only for females, but also for males. And because of the aesthetic surgery, the exposure is high. However, can we hide the actual situation by using the term screening effect? Maybe we cannot see what we have to argue. You brought out the Korean example, but can we call this situation just simply screening effect? We have to seriously consider this, I believe. Rather than those who passed away due to 3/11, evacuees who lost their lives at the shelters after the 3/11. This is the situation. However, the stress caused by the earthquake itself, this is one thing. And there's a post-stress after the 3/11. These are the two things are intertwined in a complex manner. If you look at the students as well as their children, the post-earthquake stress has a higher risk, and we have to make a sound decision on this or judgment on this. Under the situation, even within Fukushima, there are some discriminating movements existed. What's stressful most to me is the word Fukushima per se, because now Fukushima has different regions, namely Hamanaka and Aizu, and these two regions have different traditions and histories. However, we just sugarcoat by using one word of Fukushima, because from the viewpoint of Aizu, Hamanaka problem is a kind of opposite problem from them, and in terms of the radiation, rather than Aizu, Chiba and Ibaraki may have more hot spots. However, by using the word Fukushima, we put together everything, and we see the Fukushima problem as a kind of other people's problems rather than our problem. And I believe all of the Fukushimans share this feeling. Okay, Japanese people regard us as Fukushimans, not Japanese.
About the Korea thing, I'm only reporting the information that was given. I don't think there was another reason why that would be concealing anything. And I think it is well established that if you start screening for thyroid cancer, you will, the more high resolution the screening you use, the more likely you are to find abnormalities. So I don't think anything was being hidden there. But after this discussion, I'm very pessimistic, because there is a problem here, a serious problem. If this risk communication is based on the idea that there's a threshold at 100 millisievert or 20 millisievert or any threshold at all, in fact, it's dishonest. And that is really worse than not doing anything at all. There are two contexts that this risk is important. One is looking backwards, looking at what exposure people had at the time of the accident. First thing is, we don't know what it was for the evacuees before they were evacuated. That's serious, because in some places the doses that they're receiving on a daily basis over the years are not so large. There are a few times background to tens of times background maybe. But the doses that they received before they evacuated could be much higher. And they have a right to know what risk they have incurred already. But more important than that is in making the decision whether to go back to where they lived before, they need to have a good idea of the risks that they will incur on the following years. Now, something could be done about that if this problem of getting the risk, the basis for the risk calculation in terms of doses right. Up till the year 2000, there was no problem with this. UNSCEAR were admitting that you use the linear no threshold dose relationship, and therefore there was a risk even at very low doses. It might be a small risk, but it was a risk, and you should know what it is. It is only in the last 5 or so years that it has been decided that we continue to use LNT for planning exposures of workers or even the public, but not when it comes to living in an accident, a post-accident situation. And that's irrational. And there has been no international debate as to how you should manage, if at all, the return of people to contaminated regions. So that debate needs to take place at an international level, but the problem of the threshold needs to be cured, urgently needs to be cured in this current situation for Japan. So it's an international problem and a problem for Japan. And I hope that perhaps what this meeting has done is brought that now to the surface in a way that it will not be possible to ignore it in the future. That's my hope. Thank you.
はい、この問題、まだたくさん、ご意見が。
And regarding this issue, I believe there are many more opinions. However, tomorrow we will be looking more into the different aspects, which are the discourses, laws, and ethics after the nuclear power plant accident. In that sense, we can continue the same discussion we have had this afternoon tomorrow. And before that, we have the important missions of having a nice dinner and taking a good night's sleep. So that is why we'd like to conclude today's discussion at this time. There were some failures on our part as co-chairs, and like to apologize. And I also would like to thank the staff members who supported us, and let us all applaud for the closure of this roundtable discussion today. Thank you.